Hi everyone. Today I wanted to present to you a version of the research that I presented in Portland, Maine and in Washington, D.C. I've been asked to share what I've been researching, and so this is it. It is the intersection of nursing, linguistics, and social determinants of health. My background is in teaching English as a second language, so I've spent a lot of time thinking about communication barriers and language justice. When it came time to choose a dissertation topic for my PhD in nursing, I wanted to do something that connected linguistics and nursing to health equity. Now, earlier this year, I read a book called Random Acts of Medicine, and it really started making me think. One of the chapters takes a dive into a physician's, particularly an ER physician's, self-identified political beliefs to see if a ER doctor, their care changed based on what their political beliefs were. They looked at particular patient populations like those who lack sufficient housing, those who experience chronic pain, or those who've been attacked and need critical medical attention so that they don't suffer consequences from those attacks. And what they found in the data was that depending on the political ideology of your ER doctor, it does alter their care, at least for certain patient populations. And I began to wonder about nurses because we spend so much time with patients. And of course, I needed to choose a population to study. Otherwise, this question is just too large. So I focused on immigrant health outcomes. But this could be expanded to other communities or other cities. It could be narrowed. This is just a starting point, and it's where I started. According to the United Nations estimates, there were approximately 304 million global migrants. That is international migrants around the world. This is in 2020, and it was the equivalent to about 4% of the global population. In the United States, more than 25 million foreign-born residents have limited English proficiency. Now, these numbers do shift with political and social climates, but they allow us to have a place to start. There is a critical point that was disappointing, and that is interpreter use in our healthcare system is shockingly low. This is not a peer-reviewed study, and I found it to be the highest number that I could find was 50%. The numbers in the actual peer-reviewed journals was as low as 20 to 35%. And this is the percentage of times there's an encounter with someone who needs a professional interpreter and receives it. So it is not used as often as it really should be. Now, we have research that spans decades, and it tells us a few key things about the immigrant, refugee, and limited English proficiency populations. One, we know they receive less preventative care. That means fewer annual exams, fewer screenings for disease. We also know they tend to have higher rates of chronic diseases. Chronic diseases are things like congestive heart failure, kidney failure, but even things could be something like high cholesterol or diabetes. They receive delays in their diagnosis, that's very common, and their health outcomes are poorer. We measure health outcomes currently through disease management. How are they managing that disease, whether it's diabetes or cancer? How satisfied do they feel with the care that they're receiving, and how much trust do they have in the system? And those things all tend to be poorer than native English speakers here in the United States. This is not new information, but we do have to ask, why did these gaps continue to persist? Here is an organizing framework that is actually just a giant tangled ball of yarn. In the center is our patient and their outcomes, their health outcomes. Are they doing better? Are they doing worse? But interwoven with that are dozens and dozens of threads. We have a nurse's political beliefs and values. We have the way the team operates. We have the organizational culture and policies within that clinic or hospital or a healthcare setting. And then we have societal and policy context, our city, state, and country. All of these affect patient outcomes, but they also all affect each other. That's what we bring into the room. That's our input. Now we look at how those beliefs turn into action. Do we call for interpreters more? Do we advocate more for that patient? Spend more time, more energy on that patient than other patients? Do we communicate in a way that is accessible, so without so much of the medical jargon, and we really talk to them where they can understand? Because medical terminology is difficult even for native speakers, let alone non-native speakers. And then we really look at the outcomes. So does that patient trust the healthcare system more? Are they satisfied with the care? Did they receive all the services that they should have received, from social work to palliative care and pain management? And is there equity within our system and within our care of that patient? We need to dive into 3 recurring themes that I found in my literature review. And one of those is interpreter use patterns. Interpreter use is absolutely not Google Translate or relying on a bilingual family member. Professional interpreters know not only the language, but they know the dialect, the tone, and the nuance necessary for accurate communication within a healthcare setting. So, for example, if your doctor or your nurse says, take a deep breath, there could be, in the translation, there could be a dialect adjustment. There could be emotional awareness instead of robotics. And then there's the cultural context. Physicians, nurse practitioners, physician's assistants, and nurses and nurse assistants, they have to ensure that the patients are understood so that they can make a decision about their own care. There's also the issue of deservingness. And who do we see as deserving of our care and our empathy? Are refugees or non-English speakers or marginalized communities prioritized? Or does bias seep in and they're deprioritized, either consciously or unconsciously? Deservingness influences us throughout our physical examination, our ability to provide support, but also to advocate for that patient. And it's the third one, structural competency. It's easy to label a patient as non-compliant when they're late, when they miss their medications, or when they don't follow a treatment plan. But structural competency allows us to say, okay, what barriers might exist that make it difficult for this patient to be compliant? Do they have transportation needs? Is their housing stable? Are there language barriers? Do they have children to take care of? All of these things will affect their behavior. And how does our ideology as nurses shape our willingness to address these barriers versus just blame a patient? I like to provide a case study so we can look at a potential real world situation. If we have a 34-year-old Somalian refugee woman who arrives at a clinic with severe abdominal pain, she's with her teenage daughter. Her English is considered low proficiency or limited proficiency. The nurse is stressed, rough day, and the nurse just decides to use the teenage daughter to translate gynecological questions, very personal questions, instead of using a professional interpreter. The reflection I like for us to do is, why is the nurse comfortable with the decision that they made? Why is this okay for them? What biases or beliefs do they have about the deservingness of this patient that shaped their decision not to use a professional interpreter? And what is this asking of a teenager emotionally and ethically to put a child essentially into this position? We also need to talk about those systemic changes that could take place. Like, what were the barriers that made it easier for the nurse to skip the interpreter? And one of the questions that weighs heavily on me is, what kind of time pressure and productivity metrics exist on these nurses? It's faster, faster, faster. You should take care of more patients in less amount of time, which we know is not good practice. But that is a system level change that needs to occur. And then what policies could we enact that would make it easier for staff to use interpreters? What can we do? I never like to just leave people feeling like there's a problem, but what can we do? As nurses, regular reflection, just 10 minutes a week, can shift our awareness and challenge our own personal biases. I do know it's important to be realistic. Many nurses that I know work multiple jobs. They also work night shift, and they can't always take time to journal. But making sure that you have space to reflect is really important, and it requires some flexibility on a personal level. Regarding education, we need to integrate structural competency into nursing education programs. We can do this by adding case studies with immigrants or with these structural competencies in mind, and use case studies that interrogate why a patient might not be compliant. Why are they not taking their medication? Not just looking for personal failings, but looking at structural obstacles that patients face, and then advocate for changing that. We can also work to mandate professional interpreter use. Regulators and agencies are often very hesitant to mandate interpreter use in a private setting, but it's honestly just basic practice, and it's best practice. Outcomes are worse for our patients when professional interpreters are not used. Finally, we know that health disparities for immigrants are documented. There is implicit bias that affects their care, and the political ideology shapes their attitude toward nurses' attitudes towards immigration. So we need to continue the research in this way. We know all these things on the left are true. There are health disparities, there's bias, your ideology affects your view of immigration, and communication barriers, whether it's a language barrier or a patient is missing a hearing aid or is a signer, speaker of sign language. If we have communication barriers between the provider and the patient, it significantly impacts their outcomes in the clinical setting. We don't have studies that directly measure a nurse's political beliefs and then their clinical behavior. We've seen some studies in doctors, like I mentioned, but not nurses. We have a limited understanding of how these mechanisms are linked. Like, how does your political belief or your thoughts and beliefs on a culture affect your choice of care for that patient? There's not enough data to show how to intervene in this way, and there aren't validated tools even to assess ideology's impact on practice. So there's a lot of holes here, and like I said, it doesn't have to be focused specifically on immigrants. That's just my area of study, but this could be adapted. Next steps is mixed methods research, where we examine the relationships between a nurse's political beliefs and patient care behaviors. And then in the future, if we establish that there is a relationship, we need evidence-based interventions to address this as a modifiable determinant of health equity in nursing. I always like to leave with a call of action. I think we need to share our questions and concerns and reach out and have a conversation, a local, a regional, and a national conversation about this. I also feel that it's really important to engage across disciplines. So we need to connect public health officials, epidemiologists, with nurses and linguists who spend a lot of time thinking about language, as well as our legislators. We need better policies. We need reform on a macro level as well as a micro level. And the first step really is to acknowledge our own feelings and behaviors about immigration or whatever the issue is. But my challenge is for immigration. Acknowledging how we feel when we have an immigrant patient who speaks limited proficiency English, challenging ourselves, challenging our team, and challenging the institution. Health equity begins in our own minds, and we nurture it through education and policy change, and it grows stronger when we all work together. So I'm hoping that we can do that and move toward a better structure for our patients with limited English proficiency. Here is my contact information, and you saw the references. You can go back and screenshot those. I hope you'll connect. My website has a newsletter. I would love for you to join. The link, the QR code goes to my LinkedIn, and you're welcome to follow me on social media. I hope that this was illuminating on how nursing, politics, and language interact to shape immigrant health, and I hope that it will inspire reflection and collective action.